are welcoming everybody to the next session of our Congress. And as part of this, I'd like to um, say good morning, good evening, and good afternoon, depending on where you are joining us from. This session is titled Clinician Track Important Advances in the Management of People with Bleeding Disorders. For our first speaker, we have Dr. Len Valentino. He's a very esteemed individual, so I will leave you to read his accolades on the website. But Dr. Valentino is a professor of pediatrics at Rush University Medical Center in Chicago, Illinois. And his professional goal is to improve the health and well-being of people with bleeding disorders globally through research, advocacy, and education. And to advance this goal, he serves as the president of the World Federation of Hemophilia US to advance the global mission for the World Federation of Hemophilia in the United States. And he's also an entrepreneur in residence for the National Bleeding Disorders Foundation. So he has many esteemed accolades, and today he is sharing more about those and his efforts in advancing bleeding disorders. Go ahead,
Thank you.
Tino.
Thank you. So today, thank you to the organizers for the invitation to present. I was asked to talk about advances and challenges in the management of people with bleeding disorders, especially in low, middle income countries, as well as high income countries. These are my disclosures, nothing relevant to this presentation. So I've got four learning objectives here. One is define what's meant by the developing world, apply the classifications of hemophilia to patients, evaluate the major problems limiting optimal care for people with hemophilia in low middle income countries, and then potentially help you to create one or more strategies as possible solutions to address the inadequacies in hemophilia care in low middle income countries. So I'll talk about what is the developing world, what is hemophilia for those of you that may not be as familiar, the diagnosis of hemophilia, care for people with hemophilia in resource limited countries, and then how we're going to progress hemophilia therapy in these settings. So what is the developing world? The developing world refers to nations that may not have a stable economy, energy supply, advanced technologies, or where the population may lack access to jobs, food, water, education, sort of all those social determinants that we talk about all the time. The World Bank classifies 135 countries as low or middle income countries, and the population of these 135 countries is 6.7 billion people, and it represents 84% of the world's population. So a better terminology as opposed to the developing world is really low middle income countries, which is the preferred term. So how does the World Bank classify these countries? They use the gross national income. So for current 2025 fiscal year, the GNI is defined into these four categories. And you can see low income, middle income, upper middle income, and then high income countries and their respective GNIs there. Here's a world map by GNI. You can see that the high income countries primarily are North America, as well as Australia and some parts of Western Europe, where the vast majority of the rest of the world, as I said, 84% of the world's population, and a large proportion of the geographic distribution of the landmass is in low middle income countries. So countries by gross national income per capita, this is 2023 data according to the World Bank. You can see here, I just listed a representative number of some of the highest as well as some of the lowest countries by GNI. And I'm sure many of you listening in today are in some of these lowest income countries around the world. So this is particularly represented, this talk is particularly representative for you listening here today so that we can work towards overcoming some of the challenges that you face in terms of care for patients. So let's turn to our second topic. What is hemophilia? The definition of hemophilia has really been revised in the last couple of years. We don't so much talk about deficiencies of factor VIII or factor IX, although that's the genetic basis for hemophilia. This is really a defect in thrombin generation. And I put three cartoons here. One is the current thought of the cell-based model of coagulation, which is dependent on thrombin generation, which, as I said, that is the defect in hemophilia. The defect in thrombin generation may be due to the deficiency of factor VIII in hemophilia A or the deficiency of factor IX in hemophilia B. This thrombin generation can be measured. That's the middle panel. That's a typical thrombin generation curve that is representative of the healthy population, and somebody with hemophilia would have a very diminished curve. And then in the third panel on the right-hand side is thrombin generation, and you can see sort of this seesaw pattern where people who have limited thrombin generation are at the left-hand side. They have bleeding manifestations. And those that are on the right-hand side of that graph are ones that are prone to thrombosis when thrombin generation is excessive. So hemophilia, as I said, is due to a deficiency or a defect in factor VIII or factor IX. The disease severity is defined as severe, moderate, or mild based on the residual amount of factor VIII or factor IX present in the plasma. Severe hemophilia is less than or equal to 0.01 international units per milliliter. And then you can see the definitions for moderate and mild. One of the sort of conundrums that we have in hemophilia is, what do we call people that are between 40 and 50 international units per milliliter? Those are sort of unclassified because the reference range for factor VIII or factor IX typically is represented as 50 to 150. So bleeding in people with hemophilia, these are some representative photographs of primarily children, but also some adults from my practice with typical manifestations of bleeding and hemophilia. Basically, you can bleed anywhere. We see bruising, hematomas in the soft tissues, as well as muscle bleeding, or mucocutaneous bleeding, and then also joint bleeding. In the representative panel in the middle are three different youngsters with joint bleeding. On the right-hand side of the slide, you can see the progression from hemarthrosis at the top to chronic synovitis to the arthropathy that's present in people who have joint disease. And this is destruction of the bone and cartilage. So here again is a world map from the World Federation of Hemophilia that looks at the representation of diagnosed cases of hemophilia A and B. Again, the upper and high income countries have more diagnosis of hemophilia A and B. But hemophilia is an equal opportunity disease. It affects all populations and all income levels. The challenge is, of course, the diagnosis in low middle income countries where resources for laboratory testing and awareness is somewhat limited. So what is the goal of people living with hemophilia? The goal is health equity, is living a normalized lifestyle capable of doing what you want, when you want, and for how long you want. This includes prevention of bleeding, normal mobility, and of course, normal hemostasis, which allows you to participate in activities of daily living, but also participate in sports activities, have surgery, for example, and not bleed. So it's really normalizing the lifestyle for people with hemophilia comparable to their unaffected peers. So when we think about hemophilia in the developed world, we have this type of a progression where we have optimized health and well-being, which equates to health equity. And this is achieved when we have prevention of joint disease, the prevention of bleeding, maintaining factor levels at a minimum level of at least 3 to 5 international units per deciliter, but probably more likely in that 20 to 30 international units per deciliter range. And then also this can be accomplished through regular replacement therapy or substitution therapy, which we term prophylaxis. We now have the opportunity for gene therapy as well to provide regular prevention of bleeding. So the diagnosis of hemophilia is made primarily on the onset of bleeding, clinical manifestations being present, and it would be also may include a history of bleeding disproportionate to the amount of trauma that may be incurred. There may be a history of spontaneous bleeding as well. Oftentimes there's a family history. Both hemophilia A and B are inherited as an X-linked recessive disorder, and 1/3 of all cases are due to spontaneous mutations, implying that 2/3 would have a family history of hemophilia, but importantly, 1/3 do not have a family history. And as I said, the manifestations of hemophilia can occur at any age, but the more severe cases are diagnosed in infancy and in the toddler years. Mild hemophilia is often diagnosed in adolescents or even adults. I've had patients in their 40s and 50s who've been diagnosed with mild hemophilia at the time of having a surgical procedure. The laboratory diagnosis is based on screening tests, typically hemoglobin, prothrombin time, and activated prothrombin time, and a platelet count would be done. Mixing studies can be performed, especially in low middle income countries. This is a very simple way to get a factor measurement done, mixing plasma from an individual that you know that has hemophilia with patient's plasma. If it corrects the patient's plasma, oftentimes that can be help you with the diagnosis. And then specific factor activity levels can also be measured if you have the capabilities of doing that. The table that I put on the bottom is a matrix to help you determine whether a patient has hemophilia A, hemophilia B, which is typically represented by a prolonged prothrombin time. I'm sorry, a partial thromboplastin time with a normal prothrombin time, normal platelet count, and then in hemophilia A, the factor VIII coagulant activity would be decreased, while in hemophilia B, the factor IX coagulant activity would be decreased. A mixing study is done by mixing patient plasma with normal normal pooled plasma. If the PTT corrects, that would be indicative of a factor deficiency. If there isn't correction, that might be indicative of the patient having an inhibitor or a lupus anticoagulant. So mixing studies can be very helpful. If you have people in your population who have known hemophilia A, you can actually use that patient plasma to mix with an unknown patient's plasma to see whether that known hemophilia A patient plasma corrects the unknown patient, which would be then indicative of that unknown patient having hemophilia B. If it doesn't correct, then you would not be supplying factor VIII to the patient with hemophilia A. The impact of bleeding, more than 90% of bleeding episodes occur in the joints in people with severe hemophilia, and that's irrespective of hemophilia A or B. The most common joints affected are the ankles, the knees, and the elbows, which are also the most common sites of chronic joint disease. This is a radiograph, a photograph of a radiograph of patient's knees. And this was a 20-year-old who had recurrent hemarthrosis. You can see that there's collapse of the joint space because of loss of cartilage. And this is because of chronic synovitis, cartilage degeneration, and then the onset of arthropathy. Importantly, there's an angular deformity here as well. So this patient would have some significant angular deformity because of the joint impairment. So how do we care for people with hemophilia in resource-limited countries? Well, first is identification. So you have to have the appropriate diagnosis. More than 80% of people with hemophilia who are identified and diagnosed are in Western Europe and North America. But unfortunately, for example, in Southeast Asia, that percentage of diagnosed people goes from 80% in high-income countries to 15% in Southeast Asia. In Africa, the diagnosis rate is only about 8%. So there's a significant discrepancy. The graph on the bottom shows the estimated prevalence of hemophilia in one low middle income country, Cameroon, over the course of time. And you can see that there's been an improvement in the diagnosis over time, but still there's a lack of complete diagnosis. So there's still work to be done, even though there's been progress in some countries. So the goal for care in resource-limited countries is, after diagnosis, is of course treatment. And you want to correct the defect in the thrombin generation, address any joint complications. Importantly, the record keeping and a registry is critical. The World Federation of Hemophilia has the World Bleeding Disorders Registry that any country can participate in providing data to. And of course, ongoing surveillance is critical in all countries as well. The treatment for hemophilia has evolved over the past 75 years so that the life expectancy and quality of life of people with hemophilia in the United States and Western Europe has improved dramatically, and essentially is now at a point where their life expectancy is approaching that of their unaffected peers. Unfortunately, as I said, about 70% of the people across the globe don't have access to therapy. And even more so, many people don't even have a diagnosis. So it's important that we begin to address the 84% of people who live in those low middle income countries where over 2/3 of the people don't have access to therapy. The progress in hemophilia therapy has evolved dramatically, as I said, over the past 75 years. And this is a figure from a paper from Professor Minucci that shows that progression over many decades, where we have the advent of now monoclonal antibody therapy that is replacing the deficient coagulation activity in hemophilia A. And we now have a number of non-factor therapies that can provide the same level of thrombin generation in both hemophilia A and B in patients with and without inhibitors. So the progress has been very dramatic. We also have the situation where low middle income countries are still in this area where their access to therapies are really only limited to those that were available in the 50s and 60s, and really have not advanced to the point where therapy is available in high income countries of the United States, Australia, and Western Europe. So the challenge is, how do we get more therapy into these low middle income countries? And also, how do we advance the therapies that are available in those countries? So this is what we would really like to see, is that all of these products are available, and the World Federation of Hemophilia Humanitarian Aid Program is designed to be able to support low middle income countries through humanitarian donations from manufacturers that can be used to treat the most needy of those patients in the countries. Prioritization is given to the youngest patients, usually those under 6 years of age, also those who've had serious life-threatening bleeding, such as an intracranial hemorrhage, as well as those that have inhibitors. So the WFH Humanitarian Aid Program improves access to care and treatment. Not only does it provide factor products, but it also provides support to the national member organizations, hemophilia treatment centers, and healthcare professionals in these emerging countries through education, training programs, and then, of course, through the donation of factor products and non-factor replacement therapies to support patient care. Since its inception in 1996, the Humanitarian Aid Program has treated huge numbers of patients. As you can see there, almost 30,000 patients have received care through the Humanitarian Aid Program. This has resulted in the treatment of more than 400,000 bleeding events, but has importantly allowed practitioners in these low middle income countries to perform over 11,000 surgeries and care for almost 3,000 children in these countries. So the humanitarian aid program has had a significant impact, but the goal really is to get these countries to become self-sufficient with their care, and advocacy is an important component of that, so that we work with governments to try to convince them that buying product is important for them. So let me summarize some of the advances that have been made. My slide's not showing up, but most of those advances have been around the introduction of new products and the ability to treat patients not only with intravenous products, but also through subcutaneous therapy that is more convenient and can be dosed less frequently than some of the intravenous products. So advances in therapies have been quite dramatic. The challenges that remain, though, are inadequate knowledge in low middle income countries, the lack of facilities for proper laboratory diagnosis. This is a huge challenge. And then, of course, inadequate supply of affordable and safe treatment products in these countries. So what's needed in low middle income countries? A diagnosis. We have to establish diagnosis quickly. We need to educate. We need to provide therapy that's in a prophylactic manner that's initiated and sustained at home. Children can attend school, and adults are working. People with hemophilia are capable of enjoying sports and recreational activities and have minimal or no joint disease. And importantly, governments allocate funds for hemophilia. And that's probably one of the most important advocacy needs in low middle income countries. How to achieve advances in care globally? I think education is critical. We need to educate people with hemophilia and his or her family. We need to educate healthcare providers, government officials, and of course, the general population. Patient advocacy organizations play an important role. The national member organizations of the World Federation of Hemophilia are critical in advancing care globally. We also provide local training and workshops, and we provide access to the World Congress of the World Federation of Hemophilia. So attending these events is very important. We also need to enhance laboratory capabilities. We need to train more laboratory staff on performing the prothrombin time, the activated partial thromboplastin time, and mixing studies to be able to identify inhibitors. We need to have minimal equipment available for laboratory staff to be able to use. And then we also have to have a form of external quality assurance. The World Federation of Hemophilia runs a quality assurance program as well. We need to increase the supply of affordable and safe treatment products. The humanitarian aid program is an entry into doing this, but the solution is not the humanitarian aid program. The solution is advocating for governments to procure safe products so that patients can be treated. So with that, I'd like to thank you for your attention, and we'll have the opportunity for questions. Thank you.
All right. Thank you, Dr. Len Valentino, for that great talk. I know that you all are bustling with questions, but I will want to advise you use the Q&A platform to type in your questions. We will take it at the end of the next talk. So it's a great pleasure to introduce the next speaker. The next speaker is Dr. O'Brien. Dr. Sarah O'Brien is an MD and has a Master in Science. She is a pediatric hematologist at the Nationwide Children's Hospital, an investigator in the Center of Health Equity and Outcome Research at the Abigail Wexner Nationwide Children's Research Institute, and a professor of pediatrics at the Ohio State University College of Medicine. Her clinical and research interests include evaluation and diagnosis of bleeding disorders and intersection between hematology and women's health. She currently serves as the board president for the Foundation of Women and Girls with Blood Disorders. Dr. O'Brien, please take it away, your presentation. Thank you. Dr.
Thank you
Bryan.
so much. Can
Yeah.
you just confirm for me that my slide is showing and it's the full version?
I can just see the Third International Congress. I don't think your slide is showing yet.
Can you advance? Yes.
Okay, yes, that's
Wonderful.
it's on now. Please go ahead.
Perfect. So thank you so much. As mentioned, I'm Sarah O'Brien. I'm a pediatric hematologist here in the States. But today I'm really here representing the Foundation for the Women and Girls with Blood Disorders. I'm currently serving as the board president for that organization. And the FWGBD is really honored to have been invited to participate in today's important conference. And we are going to be talking today about our model of interdisciplinary care for women and girls with blood disorders. I do not have any conflicts that are relevant to today's topic, but I do serve on a data safety monitoring board for IECure and have served as an advisory board member for HEMAB. So what is the Foundation for Women and Girls with Blood Disorders? This is an organization of healthcare providers for healthcare providers. And our mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. We know that undiagnosed, untreated blood disorders have medical consequences across all of the life stages. And that really creates that need that we are trying to fill for increased education and awareness. So we have been around since 2010, and we are a nonprofit organization and serve as a source of information for physicians and other healthcare providers. And we really focus on healthcare provider education across many different disciplines. And our aim is to improve the lives of women and girls by helping to educate their providers. So we could talk about this for many different diseases, but this slide here is focused on von Willebrand disease, which is one of the most common bleeding disorders that we take care of as hematologists. And this slide is showing that even though delays in diagnosis is common for von Willebrand disease, across the board, it's even more of a problem for women and girls. So this timeline is showing that the average age of first bleeding event for a woman with von Willebrand disease is around the age of 10 years. But the average age of diagnosis of von Willebrand disease in women is 22 years of age. So this leads in women to an over 10-year gap between bleeding and diagnosis. And of course, many other bleeding events can happen during those 10 years, such as surgery, bleeding, bleeding after childbirth, or continued years of heavy menstrual bleeding. Um, I think one big reason for this significant delay in women particularly is likely due to normalization of heavy menstrual bleeding by patients and families, and then under assessment of heavy menstrual bleeding by healthcare providers. Right. So all healthcare providers need to be comfortable asking some brief but detailed questions about a patient's menstrual pattern. Are your periods lasting more than 7 days? Are you needing to change your sanitary product less than every 2 hours? Are you passing clots that are greater than an inch or 1 euro in diameter? Or are you having to get up to change that product at night? All of us providers also need to be able to educate patients and families about the signs of heavy menstrual bleeding. We need to know to screen for iron deficiency when we are faced with a patient experiencing heavy bleeding. And we need to be familiar with the treatment options to help slow and control that bleeding. The reason that it's important to educate a wide variety of healthcare providers is because women and girls with heavy menses can present to a variety of healthcare settings. This can include family practice offices, pediatricians, obstetric and gynecology practices, school nurses, or sometimes the emergency department. And the problem is that this variety of settings leads to a variety of care. The provider that patient is seeing may not feel comfortable or know how to ask a detailed menstrual history. Even if they recognize heavy menses, they may not know to consider the underlying diagnosis of a bleeding disorder. I'm a pediatrician, so in our young adolescents, one common problem is there's a reluctance to proceed with an evaluation because it's assumed that this is anovulatory bleeding that the patient will grow out of in a year or two. There may be a delay in starting hormonal therapy for heavy menses due to the discomfort or inexperience of the medical provider. And even if hormonal therapies are started and successfully treat the heavy menses, if an evaluation was never done, that bleeding disorder remains undiagnosed until the next time that patient bleeds. In our interdisciplinary care model that we promote within the foundation, you have a hematology provider and a reproductive care specialist in the same setting at the same time to help diagnose and treat the patient. And we each bring different things to the table. So the reproductive care provider is, of course, going to be very comfortable taking a detailed menstrual history. They will have detailed expertise in all of the different hormonal contraceptive treatment options. And they will also have expertise in the broad differential of entities that can cause heavy menses. The hematology provider, of course, is very familiar with taking detailed patient and family bleeding histories. We are going to have a low suspicion to look for and treat iron deficiency. And we are going to bring that expertise in ordering and interpreting coagulation testing. The need for this interdisciplinary care for women with bleeding disorders is increasing every year. This is a paper led by Dr. Allison Wheeler, one of the members of FWGBD, looking at the absolute number of female patients seen in just 18 of the hemophilia treatment centers in the United States. And you can see from the graph how much that number grew between 2010 and 2020. This is a figure created by Dr. Aisha Zia, another member of the foundation. This paper was focusing on her center's multidisciplinary clinic for adolescents, but this figure would apply to adult women with HMB as well. Many different areas of expertise are needed for optimal management. We have the hematologist, the reproductive care specialist, genetics, nursing professionals, nutrition, social work, and that laboratory expertise in coagulation testing. So I've mentioned multidisciplinary and interdisciplinary. What is the difference between those two terms? Multidisciplinary is when we think about different disciplines taking care of one patient. Maybe they have a hematologist and a gynecologist and a cardiologist, but those providers aren't talking to each other. They're not interacting and taking it to that next level. Whereas interdisciplinary is when you bring two or more disciplines into the same setting. It's a new level of integration. It breaks down boundaries and provides for optimal management. So within the foundation, we have a WGBD Clinic of Excellence model. And this is just what we've been describing, a clinic that offers interdisciplinary, meaning hematology and reproductive health expertise, that's providing the patient access to both of those specialties at the same time. And these clinics are fulfilling the mission of the foundation by providing that correct diagnosis through expert treatment for women and girls with bleeding, clotting, and other blood disorders. I've mentioned some of the advantages of these clinics already. Other advantages to talk about are reduced wait time. Patients and families can see both providers faster if they just have to go to one clinic appointment. They only have to miss one day of school or one day of work. This also provides a safe space. I'm almost always amazed by how meaningful it is to our patients to realize that they're sitting in a clinic surrounded by other young women who are also facing heavy menstrual bleeding and that we're all there to help them. Heavy menstrual bleeding can be so isolated. A young woman may think she's the only person in her friend group or the only person in her school struggling with this. So just knowing that there's a whole clinic for patients like hers makes her immediately feel like part of a community. Bringing together these different specialties also provides some unique and collaborative research opportunities. Within the foundation, we have a Learning Action Network, and that is a network of individuals who either want to start one of these clinics or have established one of these clinics. And we've grown a lot trying to meet the patient demand. So back in 2013, when we started, our center was one of 7 clinics coming together to help teach other providers how to start these clinics. And in 2025, we now have 308 members from 95 clinics representing 39 states in the US. We're also excited to welcome international members, and we now have one Canadian clinic and a clinic in the Netherlands. And I hope after this Congress, we get to meet some of you and learn about your efforts to provide this care and how we can help. This is a map of the United States showing existing clinics. The clinics in red are clinics that are for women with suspected or diagnosed bleeding disorders. We often take care of patients in these clinics also who may have personal or family history of thrombosis, and they are interested in receiving guidance on hormonal contraceptive. The clinics in purple are clinics designated for women living with sickle cell disease. And again, these are clinics where they are seeing their sickle cell provider and a reproductive care specialist in the same setting. This figure looks at just some of the existing interdisciplinary clinics. This paper looked at 34 clinics. On average, these clinics are holding 12 sessions a year, but this ranges from 4 to 36. They may see 4 to 8 patients in a clinic day. Most of the clinics were half day, although several had full days. I'll just mention that our own clinic here at Nationwide Children's, we hold our clinic approximately 20 times a year. It's held in an off-site location in one of the suburbs of Columbus. So we're not on the hematology turf or the reproductive care turf. We're in our own setting. We have a half day of clinic and we see 10 patients during that time. We're supported by myself, Dr. Farida Hamid from adolescent medicine, and our nurse practitioner, Michelle Hallam from hematology, as well as a nurse and social worker. In this paper, going back to the figure, 2/3 of the clinics were held within the Hemophilia Treatment Center, and the remainder were in a variety of locations. 60% of the clinics were pediatric only, 40% offered combined care for adults and pediatrics. Adult care is definitely still a need that we are trying to focus on and get more of those clinics open. Services also vary a bit. The majority of our clinics have laboratory services on site, are able to do factor infusions or desmopressin challenges, or are able to offer gynecology exams. One point to make, though, is that especially in my setting of adolescents and young women, gynecology pelvic exams are rarely needed. And that knowing that can be really helpful for patients in decreasing those barriers and fears about coming to see a reproductive health care specialist, that's not automatically part of the visit and often doesn't occur during the visit. Other services may include dental, nutrition, genetic counselors, and physical therapy. The sedation refers to sedation prior to the insertion of an intrauterine device. This has been a game changer in adolescent medicine in decreasing barriers to intrauterine devices for our patients. So our gynecology group at my hospital, for example, will perform sedation prior to IUD placement if the patient desires that. This has been very helpful for young adolescents or our patients with developmental disabilities or those who have experienced a trauma that would make undergoing a pelvic exam quite difficult. I wanted to end with some of the resources that are available to any of you in the audience today. If you go to our website, we have provider-facing handouts for a variety of different entities. This is an example of what to know during pregnancy for women with sickle cell disease and a handout on iron deficiency anemia. If you like to listen, I encourage you to check out the 721 Period podcast. 721 refers to a quick way to assess whether somebody may be experiencing heavy menstrual bleeding. Are they bleeding more than 7 days? Are they changing their product less than every 2 hours? Or are they passing clots greater than an inch or euro in diameter? And if you like to watch, we have a video library with brief videos from our experts on some of the most common questions that we get asked by our healthcare provider community. I'd like to thank you so much for attending and for your attention today, and I'm happy to answer questions with Dr. Valentino.
Thank you, Dr. O'Brien, for that great talk. Very interesting talk indeed. This is a question and answer session. So we will have Dr. Valentino and Dr. Sarah O'Brien taking your questions. And while we wait for the audience to type in their questions, I will kick off the question and
Hi, Prof. Prof. Nwagha, I think you might have muted yourself.
yeah, Dr. Brian, sorry about that. I listened with very great interest when you were talking about the interdisciplinary clinics. So what were some of the challenges you faced in establishing this interdisciplinary clinics? Would you share some with us? Thank you.
Sure. So a few challenges that come to mind are one is one of the biggest challenges to opening a clinic is usually finding a reproductive healthcare specialist. And we hate to talk about billing, but that's an important part of healthcare. So just navigating with our reproductive care colleagues on how we can make sure that that provider, is receiving the correct billing and credit for being in that clinic setting. That can be more of a barrier on the adult side when they're working with a gynecologist who may not be in the same hospital as the hematology provider. Another thing to think about when you're opening a clinic is who is the patient going to call afterwards. You want to make sure that they're not calling hematology and getting bounced to reproductive care and back and forth. So we're always very careful to make sure we're sending them to a nurse who's kind of comfortable in both spaces and will be able to triage that call to whether it should go to the hematologist first or the gynecologist first, or whether we all need to huddle together quickly to help answer that question for the patient. And then the last one I would mention is for our patients with sickle cell. You noticed on our map that our number of sickle cell clinics is smaller. And I think it's for many of our patients with sickle cell, it's challenging to have them go to yet another clinic setting. So in that space, I think it's really important to think outside the box and how can we embed the gynecologist into the already existing sickle cell comprehensive clinic. So those are a few barriers that come to mind.
Oh, thank for that. So I was thinking a lot of our participants are from areas where you have a high prevalence of sickle cell disease, women with sickle cell disease. So I was wondering, are there some unique considerations when establishing these interdisciplinary programs for women with sickle cell disease?
Sure. I think considerations that come to mind are, just increasing recognition and awareness of how the menstrual cycle may affect pain in women living with sickle cell disease, and thinking of hormonal contraception as not only a medication to treat heavy menses or to prevent pregnancy, but also as a way to help women with whose pain crises may be triggered by fluctuations in hormones. So it's important to bring that area of expertise. Also, when we think about pregnancy, managing how we're going to handle hydroxyurea for patients who are considering pregnancy, and recognizing, for example, the increased risk of blood clots in women with sickle cell during and after pregnancy, and how do we best prevent those complications?
All right,
Sarah,
thank you.
Sarah, can I ask you a question? If I'm in a low middle income country with limited resources, how do I go about setting up a clinic like that? Does FWGBD have resources that I could use to be able to, template a clinic?
Excellent question.
Yes. So what we have done for clinics in the States or other collaborators is we're able to meet with providers and give them some of the tips and tricks we've learned along the way. Certainly they're going to have unique considerations that we may not be as expert in. We are also collaborating with the World Federation of Hemophilia, as you know, to help provide our expertise as well in the development of these, clinics for women and girls around the country. I think it's also not everybody will be able to form one of these clinics, but it's also what are the other things you can do, like identifying a gynecologist with an interest in this space that we can continue to grow their expertise. And that can be someone that we send our patients to. And so we get that back and forth collaboration with them and they increase their knowledge along the way.
All right. So I have a question for Dr. Valentino. One Pius asked, given what we know about long-term inhibitor risk, adherence challenges, and cost burden on families, what do you think is the practical framework that should guide the next decade of bleeding disorders management? One that integrates emerging therapy, community-based care models, and data from patient-reported outcomes so that the treatment decisions are both clinically sound and truly equitable. So Dr. Valentino, do you want to have a go at this?
Sure. I think Dr. O'Brien has started to answer that question, and that is a team-based approach. We have comprehensive sickle cell clinics, comprehensive hemophilia and bleeding disorders clinics. I think that's the approach that has to be taken, where you integrate the care providers, but importantly, include the patient and his or her family as part of that care team that helps direct the care. And then it's important that you're collecting data along the way because data informs advocacy and will help inform policy for the future. So I think really the goal there is to create these integrated, comprehensive care programs where the individual can have all of their needs addressed in one setting if possible.
All right. Thank you, Dr. Len, and thank you, Dr. Sarah O'Brien. It's been quite an interesting session. You must all agree with me. This has been very great talks. Thank you so much. Very interesting. And I want to also thank our participants that joined us in this session. We greatly appreciate your time, and I wish you all a great lesson. Okay, before we go, okay, I thought we had another question. So thank you, everyone.
We do have another question, and I think it's a really important one. Can we just talk about the question, can a woman with bleeding disorders go through normal labor and give birth?
Mhm.
Oh, okay.
I just want to make sure quickly. I know we're out of time, but the answer is yes, yes. Important to have the hematologist involved as soon as possible. But yes, there are medications we use depending on the bleeding disorder that we use to help support the patient during labor, during delivery, and to avoid excessive postpartum bleeding afterwards. But yes, many of our patients have babies every year, and it's wonderful to see.
Thank you, Dr. O'Brien. I must have to close this session. Thank you, everyone, for joining up. And it's been quite an exciting talk, interesting talk. Please take the opportunity to visit the website, read about Dr. O'Brien and Dr. Len Valentino, and find out ways you can connect with them and ask more questions if need be. Thank you so much,
Thank
everyone.
you. Thanks, everybody.
Thank you for the
Yes.
invitation.